He is a Senior Research Fellow at Archers at the La Trobe University. He will present on where the PLHIV Quality of Life study came from, the innovative partnership between Archers, PLHIV and NAPWHA that made the project possible, and the demonstration of this project as a successful example of GPA and MIPA in practice to enhance the quality of services and support for people living with HIV. Dr. Graham Brown.
Thank you very much, Christelle, and thank you for inviting me to present tonight. Thank you everyone for sticking through. For those that may have heard me speak about the PLHIV study earlier today, this is not the same presentation, so just to warn you. It's more the executive sort of director summary. In particular, I'd like to firstly endorse everything that Christabel said around the role of people living with HIV within research, not just this study, but this study builds on so much of a history of people living with HIV, active participants, active drivers of research, and much of our success is we owe to people living with HIV, both past and present. Quick disclosure, I do receive funding from a range of organisations that do relate to a lot of the work that I do within the community sector and also obviously with VE. So, very briefly, a new health-related quality of life scale. This is a bit of a quick sort of context. Certainly, there's been a lot of advances around HIV treatment and impacting the lives of people with HIV well beyond just clinical indicators, and are driving changes in policy, clinical care, community programs and social practices. However, not all people with HIV are benefiting equally, which is the focus of many of the papers at Ashen. So achieving sustained treatment and health outcomes is critical to being able to identify those that are being left behind, and this will require a much deeper and much better focus on broader concepts such as quality of life. So through a whole range of things which I'll go into detail, tonight I'm going to give a bit of, I suppose, a potted history of PLHIV, in particular with an emphasis on how it came about and the role of GPA and MIPA within that study. We found that HIV community support and healthcare services in Australia expressed a need for an empirically validated and yet short and practical way to measure quality of life for people with HIV, accessing all their programs, not only for the benefits of people with HIV in improving the programs, but also at a broader advocacy, social and policy change basis. So, this brings us to the PLHIV study. What we basically did was pull the resources to develop, as I said, a short, freely available scale that would work, we hoped, in day-to-day practice within programs and services, particularly within the kind of programs which work with PLHIV peer organisations or through to clinical programs. But it was so much more than that. This project is a demonstration of a highly effective and genuine partnership of our state and national PLHIV peer organisations, research, being Archers, and health industries such as VE. We believe as a partnership that the development of a short, easy-to-use instrument could transform the way HIV organisations, health services, governments and other stakeholders would prioritise and evaluate and health service programs. We believe as a partnership we were best placed to do that. So a quick potted history. I think I've got the dates approximately right, but basically it began in 2015 with the conversation and discussions within and across the organisations involved. NAPWHA and its membership have made strategic commitment around quality of life as a key area of advocacy and development. That include investment in a whole range of programs that peer and other organisations have been running for many years, and self-efficacy, empowerment and resiliency. VE Healthcare was investing in supporting the Fourth 90 Momentum and talking development of a health literacy and management app for people with HIV in collaboration with the community partners. Archers was in the middle of redeveloping the HIV Futures study, including target analysis around health literacy, health management and quality of life, and investigating options for the development of a much shorter scale, and for many of you I can understand, many of you will be pleased to hear, investigating options for a much shorter HIV Futures study. This led to a NAPWHA satellite in 2015 Ashen with the support of VE. From there, we started to really get the momentum going. We found that there was not a lot of overlap in what we were trying to achieve, and we had, I suppose, with a lot of leadership from the POS orgs, we were able to get, I suppose, the first stage up and running. So Positive Life New South Wales, Living Positive Victoria and Queensland Positive People supported that initial stage and basically put their resources up to make it all happen. And we're fortunate enough to recruit the excellent skills of Dr. Gosha Nikowachak. We developed a joint partnership plan for stage 2 and developed a validation study and so forth. I won't go through all of it, but what was, I suppose, in particular was the fact that we built that kind of partnership means now in stage 3 we're actually in a position to have a fully funded project with sort of an implementation trial. But what is the POS-Qual scale? It's quite an achievement to go from what was, you can see in this scale, we basically developed over 100 items across a range of 4 domains, plus included a whole lot of other scales, but 100 items to get that down to only 13 items. And it's quite an achievement to do that. Tonight I'm not going to go into a whole lot of deep results around the POS-Qual scale, but just suffice to say that it's not often you get to use statistical terms in the results in the sense of the validity, the reliability and the strength of this scale, to use technical statistical terms like wow and awesome. One of the key factors that actually helped us achieve these results with POS-Qual was embedded around the JIPA principles as a direct partnership with peer-led organisations representing people with HIV. What did this actually mean? So it meant it wasn't just about the peer organisations helping us recruit people with HIV to complete a survey. It was around them being involved in the conceptualisation and prioritisation of the domains themselves, the development of the items, certainly the promotion of community engagement, a key aspect, but also being actively involved in the analysis of the data and its implications. What did that actually achieve? And this is the part, I suppose, I wanted to emphasise, is often we don't see the kind of better and successful outcomes that real JIPA and MIPA achieve. The active partnership with people with HIV enabled the study to ensure that the research rigour and sort of statistical integrity was complemented by real practical and conceptual considerations that meant the scale would be useful in real practice. It contributed to a deeper understanding of the complexity of the experience of people with HIV and strengthened the relationship across research, community and industry. It was also a non-reliance on individuals with HIV. What I mean by that, it was great as a positive person to be leading something like this. It was a real honour. But I do think, and I certainly feel that added a lot to the research mix, the team. But as an individual, I don't have the breadth of the on-the-ground insights of a rapidly changing community. Just because I'm positive is not enough to tick off meaningful involvement. Credibility and authenticity within the PLHIV community was demonstrated to that community through action more than reputation. It allowed us to demonstrate our genuineness to a community that has often been researched with little benefit. For example, being able to work with the Institute of Many to actually provide updates on how it's going and have Institute of Many and its members feel part of an ongoing part of the study, not just a community we're trying to recruit from. It's also, I think, to be able to demonstrate the willingness and commitment of Archis and VIV that we would see the study through and that we would be part of it. I think the trust our peer orgs placed in us to see this through and the commitment of VIV Healthcare to support and participate in such a partnership model. So, the momentum that I think that kind of involvement actually created is due to the partnership. For example, in Australia, we've already got these are just the ones I'm aware of. I found out there's a few more today that are already using the scale. Living Positive Victorian AIDS Council are already using it. It is being picked up in a major study in the US, the EPRO study being sponsored by VIV Healthcare, being translated into Spanish and being validated across a much larger and much more diverse sample in the United States. In Australia, we're in discussion with Bobby Goldsmith, ACOM, the VIV Healthcare My Life Plus app, and a whole range of other programs. and I've had a lot of enthusiasm already essentially from a number of the clinics, both government and private. It will also be used in HIV Futures 9 next year, and we're advocating strongly that in the sense of the national strategy, POSQUAL and this kind of short scale being a far more effective indicator of quality of life that's practical across the sector than some of the ones we've been using in the past. Now, great risk of saying more research is required. The next step is an implementation trial, and what I mean by that is we do have a scale that has been validated, is strong and it's reliable, but we don't really know how well it will work in practice, within services, within programs. We've got a lot of momentum, we've got a lot of enthusiasm, but we've got to suss that out so that we can actually put together a really effective implementation kit, and we also can know how well POSQUAL actually picks up changes in quality of life over time. So this project's going to develop a whole implementation kit and so forth, and I'm really pleased that the entire partnership, and the key thing we're looking at now is expanding that partnership beyond just the key partners we have now, but much broader across the community and clinical sector. So I'd particularly like to thank ViV Healthcare for maintaining a commitment to the partnership to fund the implementation trial, and the significant support from across all our partners to maintain that in-kind and other resources to keep it going. So in conclusion, I'd like to thank all my Arches colleagues, the partner organisations, particularly the generous support from the much brighter and the broader HIV sector, community, clinical and so forth that have helped us come to where we are now. And in particular, the 465 people with HIV that completed a survey in order to create a survey. Thank you.
Thank you, Graham. Our next speaker is Craig Cooper, the CEO of Positive Life New South Wales. He will present on community-based research projects at the state and national level, their legitimacy and how they provide valuable information about the lived experience of people living with HIV to inform the national conversation.
Hi, I'm Craig Cooper of Positive Life New South Wales. I've got a brief presentation today to talk about how we've been progressing a community research program under the POS Action framework. Before I do that though, I just want to reflect on some of the issues that Graham just raised in his presentation, more specifically our ability as people living with HIV and member organisations to work with a researcher like Graham. In terms of the relationship with La Trobe and Graham in particular, he's somebody that listens. So if he hasn't got it right or things are going off track, all you have to do is say to him, hey, have you thought about it this way? And he actually takes it on board straight away and then adjusts the practice. So from a positive person's perspective, it's not just about the partnership or the quality of the relationship, but it's actually been working with somebody who respects you and takes on board the feedback that you're giving and then does something about it, and you actually see a tangible outcome. So for example, when he put up the 13 questions and the 4 domains, the way that was structured and how we came to those eventual 13 questions, it was actually quite a robust process and a dialogue over a number of meetings and conversations to get to that point. So in terms of a respectful interaction around a process and also a survey tool, I just wanted to flesh that out a little bit because it's not always that obvious when you're not involved in the process itself. And there's been a number of meetings that have gone into the development of that tool. The reason we've started to prioritise HIV Community Research Program under the banner of POS Action in terms of NAPWHA, QPP, Living Positive Victoria and Positive Life New South Wales, we've been a number of years now, all the organisations have been working quite effectively with researchers, whether it be clinical research or social research, and there's been varying degrees of engagement across research programs in a number of the jurisdictions and also at the national level. So what that means though is that typically you build up quite a lot of corporate knowledge in the individuals in the organisation, and that's not always well translated across the organisations, and then once a person leaves the agency, there's quite a bit of catch-up time that needs to take place and quite a lot of momentum can sometimes be lost. So developing this framework that is being funded by PLHIV Healthcare, which has been fantastic, thank you very much, PLHIV. The idea about developing this framework is so that from a governance perspective, across the organisations and the body positive more generally, our levels of engagement within the research agenda can be standardised, so that we have a guiding principles and practice to help inform how we're going, and then we also have a register of the different projects and programs and the varying levels of engagement that we have within the research agenda. So just to give a little bit of background, Positive Life New South Wales also, as an organisation, has been doing community surveys now for about 3 years under Standard 2 in the National Health and Safety Standards, which is about consumer engagement and participation in the health system. In those community surveys, we've done an anal cancer survey, which had over 900 respondents. We've done a hand survey, which roughly had about 200 respondents. We've done a meth use survey, which had 400 respondents. We've done community dispensing surveys, pre and post, which had both, and that was done nationally in Victoria and also New South Wales. That survey report was read by the health policy writers in New South Wales Health, and then informed the community dispensing of the co-payment waiver implementation within New South Wales to wipe out the co-payment. So how that information is used, analysed, reported back into the community or reported into either clinical services or the health policy agenda, that information is used in quite a tangible way on a regular basis. It's not something that we do because we think it's interesting or important as an organisation. We typically do it because we hear from the community they have an interest in an issue, such as hand or in anal cancer, and they want us to do something about that as an organisation. So that's just a little bit of background about that as well. So I'd just like to acknowledge all the people living with HIV over the last 30 years that have been involved in research programs and data linkage exercises within the health system and health department. I want to acknowledge wholeheartedly POS Action and the member organisations and all the people over the last 3 years that have been involved in these conversations and where to go about the research agenda, in particular Brent Allen, who has been a very strong supporter about getting this program up and running. I would like to acknowledge PLHIV Healthcare for their ongoing support of us as people living with HIV and positive organisations. I remember the QPP session, the symposium session up in Queensland that Graham just referred to, and it was a really powerful session. So the ongoing active relationship between PLHIV Healthcare and us as positive organisations has been sustained and is enduring. I also want to acknowledge the research partners and collaborators that we've been working with now for decades, on a number of different levels, and we wouldn't be where we are today. We wouldn't be where we are in terms of the development of pharmaceuticals. We wouldn't be taking medication on a regular basis. We wouldn't be as healthy as we are, and we would not be alive. So in terms of the community research program and the governance framework, so what the project that we're working on at this point in time on behalf of POS Action, we believe it's time for people living with HIV to be in control of the research agenda, both socially, the social research and clinical agenda, and to strengthen and build on PLHIV collaboration and consultation as active participants and owners of the research program. So what that basically means is we've been sitting back now and watching what's happening in the Aboriginal community. Aboriginal people are highly researched in terms of what goes on for them, how things are going either socially or in the health system, and so are people living with HIV. I'm not saying it's the same, I'm saying it's different. But into the future, for us to remain healthy, for us to have a quality of life, there is going to be a need for ongoing research. We're now 30 years into the epidemic, so the question needs to be posed. What does that mean for people living with HIV? Where do we sit within the ongoing research agenda that needs to continue to be progressed for us to remain healthy and alive? At this point in time, when you look at the power balance between us as people living with HIV and patients within the health system, and also the researchers and the clinicians, when you look at that arrangement, we're not always in a very powerful position. So the other issue that I want to pick up on is about data sovereignty. So this is basically about research collaborations being driven and controlled by people living with HIV, including ownership of HIV data sets and health information. So what that looks like at this point in time, it's quite minimal. Sometimes it's quite tokenistic when we're being involved in cure research, and sometimes it's a little bit more front and centre, for example, in the development of the post-qual scale. So on any continuum, we can be completely left out of the conversation as the research is being developed and progressed, and we only find out about it 5 years later that this has been going on. Or, at the other end of the spectrum, we're fully front and centre, we're involved in the research design, we're involved in the ethics application, we're constantly consulted and running focus groups, we're actively participating. But typically, we're only there as a collaborator or an investigator. We are not always controlling the research agenda. So, in terms of the research governance framework that has been funded by VIV Healthcare, the process is being progressed and developed between October and March. And what's going on is we're drafting key principles to guide the governance framework. We're meeting with the AHMRC in New South Wales to have a look at what their ethics process is, because we think we can learn a lot from Aboriginal people and how Aboriginal organisations have been managing their involvement in research, and ensuring that Aboriginal people remain really powerful in that conversation and in that process. We're also reviewing international community research programs, similar to what's being produced in Australia. So Brent's provided some really good examples of some of the programs that have been running already for community research in Canada. So what we're aiming to do is to improve the health and quality of life of people living with HIV, to improve the coordination and transparency across peer-based organisations conducting or partnering in research programs, to develop and implement a research governance framework to guide our practice and priorities against the national statement. When I'm talking about the national statement, I'm talking about the research statement. And to, as I've mentioned, increase transparency and standardisation across research partnership and programs. So that's going to be the first step in terms of where we're going right now and what's going on. What this will look like into the future, potentially, will be the National Surveillance Program could change quite a bit. If, for example, POS-QOLs picked up as a part of the National Surveillance Program, how patient-reported outcomes fit within the surveillance program and what that looks like into the future, it could be quite different. This is a part of the stepping stone. The work that Graham's doing, the work that we're doing with POS Action is a part of the stepping stone, moving us in the right direction. I think that we need to have a call at this point in time. We need to actually try and ensure that from the National Surveillance Program perspective, we now start monitoring people living with HIV hospitalisations. We need to start monitoring people living with HIV deaths. What are the causes of death? What are the reasons why people living with HIV are being hospitalised? Those as measures from a quality perspective in terms of data measures that will tell us as the positive people if the doctors and the health system is actually managing us well. We can no longer have silence and invisibility about this as an issue. We need to have better data. And finally, I think as a part of the National Surveillance Program, eventually what I'd like to see is POS-QOL introduced as a part of the surveillance system in terms of as a patient-reported outcome measure. Thank you very much.
Our next speaker is my pleasure to welcome Dr. John Rule. He is a consultant at NAPWHA and an associate lecturer in the public health and community medicine at the University of New South Wales.
And I just want to start off by saying I didn't know I was going to do this presentation until the end of last week. So late at night I thought, if I can't research, it's not my revolution, with apologies to Emma Goldman. Now, just as a test, who knows who Emma Goldman is? Okay, I'll tell everyone else at the end. So the next thing is, let's talk about community-based research. That's what I thought we were here today to talk about. So I did a bit of research, being a researcher, and one of the best articles that I found on community-based participatory research was this one by Rhodes, Mallow and Jolly, published in 2010. And they said it's a new and not so new approach to HIV prevention, care and management. So I thought it might be useful just to recall what some of those principles might be. So the principles that those authors talk about as being essential to community-based partnership and research are that structures for full and equal participation in research community members, including those affected by the issue being studied, not just the inclusion of partners or consultation, but the identification of priorities for research at the beginning of the research process. This is stuff that's echoing, I think, what Graham and Craig have already talked about. A sense of openness and trust amongst those community-based partnership research members, an emphasis on co-learning, mutual transfer of expertise, sharing of decision-making, and power among community members, and Craig talked about that issue of power earlier, and that must exist between organisational representatives and academic researchers. Further principles is that there would be mutual ownership of the products of the research, that the research belongs not only to academic researchers but also to community organisations and representatives, and that in the process of doing the research it actually increases individual and community capacity through the research activities themselves. And one of the other principles that these authors talk about, which I thought was worth recalling, is that it's commitment to long-term partnerships that are ongoing, put the G in there, and not tied to one study or project. So I guess the kind of notions that we're talking about are about things not happening just here or there, but in a kind of strong movement forward. In the information that I provided, I said, well, what can I contribute? I started working at NAPWHA in 1999. That was last century. So I got all the old annual reports of NAPWHA, and I thought, I'm going to look at what NAPWHA used to do in the years 2000 and 2001. Well, NAPWHA had HIV positive representatives on the Vaccine Research Consortium. They had representatives on every working group of what was then the National Centre in HIV Epidemiology and Clinical Research, and representatives on the scientific advisory committees of the Australian Research Centre in Sex Health and Society and the National Centre in HIV Social Research. In 2000 and 2001, I know this is ancient history, but I think we've got to know this ancient history. AFAO and NAPWHA organised a HIV Research Summit. So it didn't rely on the national centres to organise that summit. The community organisations did that themselves. Also, with great respect here, NAPWHA convened a social research planning workshop with the National Centre in HIV Social Research and the Australian Research Centre in Sex Health and Society, and that was facilitated by Lavinia Crooks and Michael Hurley. In 2001 and 2002, there used to be a process where the Commonwealth Government would have a quinquennial, which I think is a 5-year review of the activities of the 4 national centres. And NAPWHA, along with other community-based organisations, Scarlet and Able and others at that time, participated in a review with the Commonwealth about the activities of the national centres. In 2002 and 2003, the NAPWHA Treatment Officers Network, along with the AFAO and the representatives on the National Centre in HIV Epidemiology and Clinical Research committees, they reviewed the national research activities, and that was facilitated by Professor Marion Pitts from Archers at that time. And also there was a formal training days, I think it went for 5 days actually, for NAPWHA representatives who were on these bodies, because they were pretty heavy scientific oriented work, some of them in social research and some of them in behavioural research. But so the training days for NAPWHA representatives in clinical research and analysis skills was something in 2002. Just a reminder for those who may not have been around then, and there are people here who were, but for others, these were the groups in 2003 that people living with HIV were actually represented on, or if they weren't someone living with HIV, they were a trusted advocate and representative of people living with HIV, and I think that's a very important point. So there was the Antiretroviral Therapies Working Group, there was the Australian HIV Observational Database Steering Group, there was the HIV Surveillance Committee, there was the Immune-Based Therapies Working Group, there was the Neurology Working Group, there was an Oncology Working Group, there was a Primary HIV Infection Working Group, there was a Research Coordinators Working Group, there was a Toxicology and Pharmacology Working Group, and there was a Biomedical Prevention Working Group. That was added in 2004. So fast forward to 2007, NAPWHA was then represented on 20, according to the archives, NAPWHA was represented on 20 research advisory committees or research working groups, and these now included groups focused on HIV genotype resistance tests and also the International Insight Network of Clinical Trials and the Immunovirology Research Network Committee. So I hope I'm trying to get across a picture of a big range of particularly scientific research that NAPWHA as an organisation had representatives in each of those areas at that time. Very fast forward now to 2017. I've got lots of question marks because I might have done that slide late at night, but really it's because I can't kind of collate all that information. Hopefully it is being collated, but I think it would be great if it was collated, the range of representative capacities that people living with HIV are playing on different committees and advisory structures and research projects at the moment. Because this is me now, I'm speaking, what I see now is that there are diffuse HIV research projects and agendas. In 2000 and 2003 and 2004, that period I was referring to, you know, there were 4 national centres in research, so you knew where the scientific research was going on, you knew where the behavioural research was going on, you knew where the social research was going on, and you knew where